whatever you want. All right. Well, letting people in the door now, so they'll start filtering in here, and then we'll get going here a couple minutes after. But well, I'm happy to hear about all that. That's fantastic, and
Yeah,
looking
awesome.
forward to our discussion here today.
Awesome.
Give a couple minutes here for everybody to jump in. As you're joining our July Fireside Chat, feel free to read through the about section of our guest, Dan Thompson, and then I'll do the intro after that. But all's good on our front out here. We got some nice weather today, and trying to convince myself that working is what I want to do this week instead of being on vacation with the kids. But
nice. I see some familiar names coming in. It's nice to see Mark Collin out there, Mark Grolski. I see some people that I know over the years. See Paul Merrill out there. Very cool. Very cool. Nice to see old friends and make acquaintance with new ones.
So you think they're here to see you or see me?
No, that's definitely not. They're coming to see you. They're coming to see you.
They want to see what shirt I was wearing this week. Yeah. Dan was poking at my shirt, but it's July. It feels like it should be a poolside chat instead of a fireside chat. So I'm going with the summer attire. Dan's making me look bad, all dressed up though.
Well, you're like a summertime guy standing in front of a winter fireplace. So just saying.
I know. You got my flip flops on. I'm ready. Let's go swimming. All right, let's get this party started. So welcome to our July Fireside Chat. We will have our guest Dan Thompson speaking to AI and underwriting and how that transitions into self-funding. I know that that's been a topic of conversation amongst many of the people that I meet with over the last several years is, how do you transition groups when you have a limited amount of data into the self-funded space and even further into the reference-based world and the technology is coming around now that I think is making that a lot easier. So Dan's going to be jumping into that. As far as Dan's background goes, he is the Chief Benefits Officer for Vensure Employee Benefits. He's seen, this is not in the bio, this is just my opinion, he's seen a wide range of skills and talents and knowledge around this as he's gone through several different acquisitions, as he's brought groups into Vensure. And what I've learned about him is he's a wealth of knowledge. He's always willing to share, and he participates in many different groups around the country where we have the pleasure of running into each other. So it's a pleasure having you on the show today, Dan. Excited to hear what you have to say. And as always, the audience, please ask questions as we go through this. I'll thread them into the conversation as we go, and we'll take it from here. So Dan, turn it over to you.
Awesome. Yeah, Heath, thanks for having me. And as always, thank you to you and the 6 Degrees team for what you're doing for our clients. We're super stoked about the continued industry forward growth in reference-based pricing and all the new innovations that keep coming with that you guys keep spinning off. So keep up the great work, and again, thanks for having me here today. I do appreciate it.
Hey, I do this to everybody. I always think of something after I've moved forward, but for those that are new to the Fireside Chat, please use the Q&A button at the bottom of your screen on the Zoom browser. Put your questions into that. You can use the chat for, if you want to make comments or something, but if you got a question, please use the Q&A. I'll be reading from there. And this recording will be available on our website, as are all the past Fireside Chats. So you'll be able to find it there as well. So, okay, back to you, Dan.
Awesome. Yeah, thank you. And for those that I don't have the pleasure of knowing that joining us for today's webinar. So I'm Dan Thompson, as Heath said. I'm presently multiple roles, right? So Chief Benefits Officer for Vensure Employer Solutions. We're probably the largest PEO payroll company you've never heard of. So we're now larger than ADP, and Paychex are the largest PEO payroll company in the country. represents a little bit more than 21,000 employers and about 2.5 million worksite employees when it comes down to the clients. 88 acquisitions in. I've learned a lot in just under 3 years. Thompson Risk was my second agency. So for those of you, some of you that are participating knew me when I was a small fledgling benefits broker at a small sleepy P&C agency in Florida, which I left after it sold to Acrisure and started my own. And then I formed a joint venture partnership with Vensure with the idea that I would come in and take the role of chief benefits officer and run benefits for all of the PEOs, and then continue to be CEO of my brokerage, which we've grown and added a tremendous amount of staff. And not only that, but also benefit sales consultants to support all 55 PEOs and then another 30 organizations, some of which many of you may be familiar with, like AIM. So AIM Care Management is a venture company now, and we're pursuing more acquisitions in the healthcare space. But just a small plug, many of you probably know I'm very connected to who I consider an industry mentor and somebody who I've followed forever since the beginning of my career, Nelson Griswold. So I've participated in most of his Ascend conferences, and currently participate, as well as a few of our associates, in his mastermind organization. And just a small plug for our documentary that hit the street. If you haven't seen it and you'd like to, feel free to connect with me on LinkedIn. I'll send you the link to the full documentary if you'd like to watch it. But it's garnering a huge amount of interest for the advisors who are the producers for the documentary, one of which is myself. And so, we all know about this movement. We've been talking for a decade plus about breaking the status quo and talking about, transcending a fully insured employer into a self-funded plan. And how do you do that? And what nomenclature do you use? And how do you become from a commodity pusher and selling BUCA plans over to doing more of a strategic consultative approach to more of a self-funded plan? And so, we're not asking traditional advisors to abandon the way that they do business because they've built successful practices on the BUCAs, but start really thinking about how to change and evolve their practices into the next generation, which is in essence what Next Gen really is trying to do. So this documentary is a culmination of individuals like Renzo Lozati from USRX Care, Keith Smith, a surgeon from Oklahoma Surgery Center, Wendell Potter, a big known whistleblower from the Cigna Humana executive days that he spent, Nelson Griswold himself, a handful of other CEOs, surgeons, including employer clients of mine, and some of the other producers that spoke specifically about their experience when they moved from BUCA plans over to unbundled non-commercial plans, all of which my clients have 6 degrees for their RVP. So, looking forward to having you take a look at that documentary, and thanks, Heath, for again having us here so we could showcase a little bit of airtime about that.
Happy to have you.
So Lindsay, if you want to pop to the next one, it's fine. So this whole idea of which is why Heath asked me to come on today was, we're killing it right now, and I'm excited about the next gen advisors who are in our mastermind. I'm kind of helping co-manage mastermind now with Nelson. It's a privilege to be able to do that. I saw some opportunity there to really help recruit better quality, higher level advisors that have big books of business who really are moving the needle like we are, from moving clients from fully insured to self-funded. And being able to get data has been huge. So we rolled out this project called Next Gen Benefits AI. And in essence, we built a template that if advisors send us a census of a group, we're able to get de-identified medical and prescription drug histories on that group. So we're going to tell you a little bit in this webinar about how to do it, what we're doing, and why that's important. But it's dramatically changing the ability of the advisor to be more skilled and be able to close more deals and help move these clients from fully insured over to self-funded even faster than they ever could have before. Next slide, Lindsay. So, right, obvious question, how does it work? Well, if next gen advisors come to us, and even those that are in the industry that are really wanting to learn and harness the power of AI driven data, they send us the census in a specific format. And if anybody out there would like to, have the opportunity to send a census for a prospect that you're just dying to get the data, right? You've got a client who's in a C-level role facing a huge renewal increase. They've got a traditional, big letter house broker that's out there that's telling them they're getting a 20+% renewal increase. They can't tell them why, or if they do tell them some information as to why, it's a very limited data set of claims. And they can't tell any reason, they can't give any real credible information as to why. And of course, the carrier puts their heels in the ground because they want to protect their margins, right, which are now managed down to a smaller margin thanks to ACA. And they don't want to share more information to justify that they shouldn't be giving these groups these huge increases. So we're able to pull de-identified, wouldn't be right of us to have it identified. We're able to pull all of the de-identified medical and prescription drug data for the client. So when we look at that, right, when we send that census data to our team, we own an AI company out of California. It's called Violet Berry AI. So Violet Berry is able to, we worked with over the last 2 years with the School of Health Informatics at Notre Dame. So our PhDs put together an incredibly powerful tool that combines industry leading AI tools with additional AI data sources. I think it's quite frankly the fastest in the industry, the greatest in the industry. And it'll show all the high cost claimants, current, last 2 years, and back as far as 4 years, ICD-10 codes, prognosis, treatment. And then it will also show high cost prescription drugs. It will also estimate the amount of deductible exposure that a given group is going to have. It will show the total estimated spend of medical and prescription drugs. There is a little bit of a caveat in there, and we've been talking to a lot of stop loss companies about their feeling and their confidence around it, right? And what we've garnered is that so long as 75% or more of a census gets hit, in other words, if they've had 75% or more of those people on the census that they got the data from, then they feel like that's statistically reliable to be able to make decisions and offer quotes. The good news is we're able to we've consistently been hitting 90 to 94% data hits. In some cases, 96, 99%, which is even more statistically reliable. So then what we're teaching these advisors, these consultants to do is analyze the data, right? We all know, those of us that are more skilled advisors, the 3 big problems today that clients are facing are cancers, musculoskeletal bone joint, and diabetes. By and far, most groups, we had one this past week, it's about 11,000 lives. They're about to fire Willis Towers Watson and move to us. Good day at our office, bad day at WTW's office. And the main reason is that there is nothing being done from a risk mitigation standpoint to lower the cost of high cost diabetes drugs. So what we've done is the advisors take this data, right? And then go to solutions providers like 6 Degrees and say, hey, had this group had RBP last year, what would that pro forma have looked like? Go to your fiduciary PBM, take the data and say, what would this have looked like last year? Go to your other solutions providers like Diathrive, right? We're not here to, as Nelson always calls it, open kimono, tell all the secrets, but Diathrive is another big partner of ours that we use when it comes to diabetes solutions. So work with the key vendors, create the pro forma, create the situational analysis, do the risk evaluation. The big brokers can't do it. Work with the key stop loss vendors to quote the risk, and then obviously develop both RBP and traditional carrier solutions to go around it. Now, every group, we can't write every group, but this has been tremendously revealing when it comes to taking that data and then forming a sellable proposal, building a value proposition, and telling the employer the story of how we're fixing healthcare. So that's kind of that's the sauce, right? That's how we do it, and where we're standing with that today. What do you think, Keith?
I think the the fact that you guys are taking action to make these things happen is the first step. I think a lot of people are scared to do it or don't know the steps to take. And having resources like you that are willing to share this is a phenomenal first step. I'm curious as you go down that path, though, what are some of the stumbling blocks that people run into when they make that first step to get the data or to do the analysis? What are some of the holdups?
Yeah, some of the obstacles have been incomplete data, right? They send us a census and it's missing, vital information. We have to have, as our technologists and our DevOps team always says, it's like good data in, good data out. If you put bad data in, right, either A, you're going to get no result, or you're going to get bad data out. So, it's the advisor has to have that strategic discovery conversation with the prospect and really truly help them understand what the destiny looks like. And then the potential buyer will be motivated to get that information. Just putting together a scrap census and sending it over to us to get AI data ain't gonna work. It's got to be intentional. And then you're setting the expectation with the buyer that I'm going to come to the table. And by the way, some of our advisors, I'll name a few, like Brock Bertrand is one good example, a successful advisor in the Midwest. He's used our next gen AI formula to actually win BORs. So even though, to your point, Heath, it isn't easy, but having the conversation changes the conversation with the potential buyer, something about something they've never heard before. And he may, in his situation, he won a couple very large group BORs with the idea that, hey, I'm going to take it over for you because we can help risk mitigate some of these things and maybe eventually be able to move it to more of a self-funded scenario. So it's a good question. Heath, should we address questions sort of at the end, or do you want me to address them ongoing? There's only one right now.
You can ask, or as they come in, if it makes sense during your conversation, go ahead and do them at the time.
Yeah, sure. Yeah, so there's so many sources of information that are all aggregated together out there. You just need to know where to get it. And obviously, for us, it would be like let's just like liken it to Coca-Cola, right? Are you going to ask them for the recipe for Coca-Cola, and they're not going to give it to you unless you figure out the combination to the safe that's in Atlanta, but nobody's figured that out yet. But I will reveal some components of it. We are using some data information from sources like Milliman, Gradient, Verikai, a few others that have made real good strides in the industry, but also from a health informatics standpoint, we're also able to use medical information bureau databases. These are companies that there are probably a dozen of them that are feeding data to life insurance companies. And by the way, the great question again, but AI is and the ability to underwrite is so dramatically moving fast. It's such an incredible catch up. You can't catch up to the pace of it. But as an example, we run personas campaigns. So, we have our clients agreeing that we can, on the payroll side, offer the clients life insurance. So, when we were in Key West a couple months back with our mastermind team, and we had some advisors sitting at the front of the room, and we were talking about what are some non-benefit related insurances that you could do, some strategic things, right? One thing that came up was, by the way, it is insurance, but it's a different conversation. Key man, cross purchase, buy, sell. And a couple of the advisors sat in the front and said, well, yeah, I wrote an employer, it was a group client of mine. I did his key man for 2 million and made some good revenue. And when I went, I said, okay, we used AI and we streamed through 20,000 lives and determined what percentage of those would be super preferred, and non-preferred and declined. And then we pared the data down and we had 1,200 super preferred people. And in one stroke, we wrote 400 policies. So that's how you leverage AI into your insurance practice, is you have to do it at scale. So in essence, going back to the question, right, we're pulling data that is from reliable sources that insurance companies pull from, care management companies pull from, underwriters pull from, and pulling all those streams with one AI tool in a matter of milliseconds to be able to produce a more accurate and reliable data. And the answer to your question, it is actual data, and it is actual real-time data of what the individual's medical and prescription drug histories are. But again, de-identified, because it wouldn't be right of us to know exactly what that is. Next slide.
Hey, there's a couple other questions that came in during that. The first one here, would the AI tool benefit a group that is already self-funded, part A, and or larger groups like 500 or 1,000 life employee groups?
Yeah, I love that question. 100%. So if you're an advisor on an existing self-funded case, and you're looking at raw actual claims data as it's being fed through the TPA and being looked at and garnered from a variable standpoint, but maybe there's conditions that are out there in that group that are either people not using, they're not medication adherent, or they're not taken care of, that could garner an HR team. Think about the RAND study, right? Wellness has 0 ROI. Ask Al Lewis how valuable wellness plans are. He'll tell you the real story. But from a perspective of clinical wellness, and again, I hate the word wellness, but if you use it from a clinical risk identification standpoint, yeah, run the data. And guess what? What if you find out that there's 29% of their employee population have diabetes, or there are people who are in remission, right? What are some educational things that you can do as an advisor for that HR team that actually can move the needle, right? And that they can, again, not identify individuals, but provide broad education that's valuable. 500, 1,000, absolutely. We just ran it on a very large janitorial custodial client of ours that has 34,000 employees across hospital systems. It's amazing the data that we're able to take from the raw data and then create it into a really nice report. That's a great example of how the client could be doing some risk mitigation. Yes, we're aggregating data from a ton of different AI vendors, and then different sources from what existing life insurance companies and other insurance related companies use to pull. And in essence, it's almost like Heath when he's out in the water fishing, throwing a giant net and pulling them all in. We're pulling every possible identifiable data source. That wouldn't be any fun though, Heath, right? Because you like fishing one salmon at a time instead of getting them all in one boat, right?
I do. Are we pivoting now to my fishing habits, or okay? Hey, one which I'm happy to talk about. I actually did a presentation for my kids' school on my salmon hobby, but different story.
Nice.
In regards to the question that Mark had, if you also have a self-funded plan of that size, you should be able to get traditional claim runs, and then from the 6 degrees side, we can take that, and this is what Dan had mentioned earlier, and show you what that experience would have looked like
Yeah,
under a reference-based or a narrow network with reference-based type plan. So
yeah, absolutely. More, better advisement when it comes to what the client should be doing next year, and opening their eyes to things like, what if you would put in Livongo or Diathrive for diabetics? Like, well, how much more of the needle would that move? And, and we'll talk a little bit later about it, but, I'll share a little bit of color around how knowing this information can pair with those solutions and then what it actually yields. And this on the screen now, it's a group in Miami that we did that had United Healthcare. We were already the agent on it. And they use one of our HCM tools, namely as a company that we own. And it's been incredibly successful for us as we acquired the old Namely brokerage. And what we found with the Ventec solution, those of us that have been around long enough to know the freemium approach of the old Zenefits attack, where they would go out and say, hey, give us your payroll for free as long as you give us your BS, right? Because as soon as the renewal came around, they weren't insurance advisors to understand how to do this transference from a fully insured to self-funded. They just assumed that the client would accept a less bad renewal. So in this case, we took a client that was getting a 42% non-budging net negotiated UHC traditional fully insured renewal increase, pulled the data, and the HR director there, who ironically had been a client of mine for a big national beverage company, He's like, Dan, he's like, our people aren't sick. He's like, I know our people. They're all young. They're healthy. They're riding bicycles to work. They're, spunky. He's like, maybe we've got some conditions that we don't know about, but my HR team is sophisticated in that we're friends with the team. They all work in the same building. It's not a work from home acceptable company. He's like, we know each other. They have a cafeteria. They got a cook there. It's a very cool high tech company. So we pulled the data, and sure as can be, like there's no conditions that were present that were on the reports shown by UHC, which were limited, by the way. They couldn't provide the information. It ended up being that we could write it, and in that particular case, and we like to diversify, we put that client with Benefit Indemnity Corp and BIC, which is a Roger Vane design company, has a great offering. I liken it to an Angle or a Excel, or there's so many of them now. Catalyst is one. Fair cost health plans, Total Control, High Plains. I mean, there's a zillion of them out there now. That are these private labeled programs that benefit advisors that are smart are building in their markets. And we're testing some of those around the country with our payroll providers. So it's been great for us. But we wrote it as this big, unbundled, non-commercial, self-funded group, saved them 300 grand. And we did a combination of Cigna PPO with RBP. And in this case, BIC did a great job for us, utilizing 6 Degrees as the partner to say, hey, look, there's about a 20% concession if you just get rid of the Cigna PPO here. So RBP, in their math, the algorithms, right, when you look at the fixed and the variable and how that client's going to fund it, no different than how they were funding their old goofy UHC plan, they're going to just fund to the max on the BIC, and it's a huge home run. And I'm happy to say that they were a January 1st, and we just did a fairly mature 6-month look, and it really wasn't anything valid until about April. As you guys all know that are experienced in self-funding, takes the first 3 months are not really reliable. It's more immature. They're running awesome. I think their loss ratio is 42%. So it does work, and we've done it, and happy to show the actual evidence that we have. Next slide. So Heath, do you remember when you guys at 6 Degrees, took a daring bet to help me move Vensure and all of its companies across the whole country to self-funding, and maybe what I refer to as rip the Band-Aid? Remember when we did that?
I do. I do.
Yeah, so Vensure is a amazing story. Obviously I'm their chief benefits officer, but I remember walking into the HR director's office, who's still with us. She was the HR director when Vensure was, I think, 2021, not too far ago, 50 employees. And now, and this case study has to be updated, we're about 5,800 employees. At the time of this case study, we were around 4,000, but we're acquiring so many companies, it's insane. But they had an Aetna fully insured plan for about 1,016 employees enrolled at the time. And of course, I took over VOR and managed it on the Thompson risk side of what I'm doing. But I was like, this is crazy. So we ripped the Band-Aid. So 41-ish states at the time. Now we have employees in every single state, but completely ripped it out of Aetna and just took the chance and said, screw it, I'm going to move it RBP everywhere. Well, I learned my lesson on that. Pretty hard in some rural places, but at this particular point, we now have this, as of this case study, it says 2 million in surplus, but we're closer to the 3 million in surplus. And at this particular case study at the bottom there on the left, it says the upcoming 2024 renewal, we're expecting no increase. We had 0% increase to our employee contributions. We had no need to net increase our funding of the plan. And now we're heading into 2025, and we're setting our working rates to where we're going to charge the employees more for Cigna, because we have this Cigna variability type plan. And not only are we going to continue to pay 100% for single for our guided RBP plan, but we're going to start contributing heavy on spouse, child, and family. And by the way, we did this with plan design as reward, right? It's the carrot stick approach. RBP is awesome, but it takes an additional nurturing when it comes to things like working with rural hospitals and working with the 6 Degrees team. Radel, Melissa, I mean, they're all incredible, but they've spent a huge amount of work with my HR team on the Vensure side to work through every single painstaking claim when it was presented to our plan, as long as it met what was implied in our 6 Degrees contract, right, for facilities and professional. But if it goes over that, 6 Degrees comes right to work and says, hey, let's go get on the mat and figure this. Are we going to litigate it? Are we going to pay it? Are we going to settle it? Are we going to beat them up? What are we going to do? And that's exciting to do because it really is true cost savings every single time we've done that. But we've done about 7,800 claims. A lot of those were, 97% of those, if you will, were tier 1, where we're using AIM, and our employees, think about that, 97% of 7,700 claims. That's a shitload of claims. Am I allowed to cuss on this, by the way, Heath? Like,
I don't have a beep button, so apparently, yes,
it's okay.
you're
It's
good to
okay.
go.
Sorry, sorry. No, so but 230-ish some claims, that 3% were harder to deal with from an administrative standpoint, where a facility would, put their foot down in a rural area like Billings, Montana, or West Virginia, or South Carolina to some regard, and some places in Florida. But I'm happy to say we've worked through every single one of those, and we were able to establish single case agreements. So that's success, but it takes a hell of a lot of work. But the results, right, for our private equity guys and our other companies, this alone has earned us the business of being able to be the advisor for a lot of big PEs that are behind Vensure. And we're doing the same thing here for a lot of their portcos and moving our advisors into those deals. But I thought I would share the success story of our own employee group again, as I think a lot of it is attributed to RBP. And it's a hell of a reflection that you can do RBP on a national basis without the nightmares of pain, as long as all parties are aligned. Heath, what do you think?
I agree. And there's things that we've built into our program that I think help alleviate a lot of the pain points that others may have experienced under other RBP type plans. And there's additional steps that kind of, I think, help put an easy button into the program that you guys aren't currently using. But for those that don't want to be quite as involved in the decision-making process and or approval process, when we hit those thresholds, we can add an additional layer with our legal program that automatically kicks in, and it's eliminates another 95.5% of that carryover into that. So there's different ways to do it. And I think it all depends on the risk tolerance and the vision of the plan and what they want to do with RBP. But we've set up the tools to be able to do it based on that.
Yeah, and I think too, we've there's a lot to be said for other strategic vendors. I mean, RBP is for sure critical because such huge liability comes in the professional and the facility spend, but the drugs, I mean, a lot of I see, for those that I know on the call, they all know, far too closely that from their experience that drugs is the big problem. And we've been hugely successful with USRX Care, just sharing who we really are aligned with on the fiduciary PBM side. Renzo's built a hell of an operation. And that's been super successful, not just for our employees internally, but also for our clients. And it's also part of the BIC program, our max funded program, and then script sourcing. So, there's I will tell you what's very interesting, and I think I haven't told anybody this yet, but Thompson Risk is also in global benefits, right? So we have about 3,000 employee lives covered in Canada, and then about 3,900 employee lives covered in Latin America. And how they do business in the true North America and Canada is very different than domestic US, very different than South America. Very similar, but very different. And what's very interesting is, and I hope that this comment helps maybe release the hesitation tide that people have when it comes to international meds. But the clients that we serve in Canada, for our clients up there, which are WePay, which is a big payroll company we own, and another one called Canadian Payroll Services, prescription drugs is a service, a professional service that you purchase out of your paycheck in Canada. And the very elemental things that are part of script sourcing in the United States are exactly what they do in Canada too. They get coupon codes, manufacturer's assistance. They build it just like we do here. So a lot of people tell me like, oh, is there an efficacy issue of the drugs? No. Is it a problem based on the origin of the drug? No. Are there some limitations? Of course. Aren't there limitations to everything? But as part of this case study, and I don't think I have it on here, I might, no, I don't. 87 of our employees, 87 placed specialty meds through script sourcing. It was about a $1.9 million evacuation of expense from us that we would have had to pay had we not had the specialty drug mitigation tool in place. So that was massive for us. We're running at about a 71% loss ratio. It's pretty damn impressive for a group of this size with our age and demographics. And it'll continue to just keep improving year over year.
Hey, Dan, one thing that you don't have built into your case study here, but I think is essential for the success of RVP, especially when you're having acquisitions, is the education and training for new employees coming onto an RVP plan, and then subsequent training as you add additional companies to the organization. What did you do to find success there, and any best practices you might recommend to the audience?
Yeah. So when you talk about open enrollment to our HR, to a normal HR team, say in a prospect, they look at it and view it as once a year. When you talk to the HR team, my HR team at Vensure, our HR leader and all the generalists and the teams that all go below her, those teams, they look at open enrollment as every month because we're constantly acquiring. So we just recently, and they've been announced, we acquired Tandem HR in Chicago, ExecuPay out of Texas, and Implicity in Southern California. Good day at the office for us, bad day at the office for their external brokers, but that's just another thing that we do. But our HR team has to say, okay, these 100 employees in the Chicago and surrounding areas are going to come into Vensure, and they're going to do a very down and dirty open enrollment. We may even go to 6 degrees and say, okay, what were they doing before? What is this going to look like? Are there RVP obstinate providers in their area? Can we quickly jump to ensure that there's single case agreements out there that 6 degrees is negotiated that we could utilize and hop onto? Are there single case agreements that we need to jump in and negotiate? Are there going to be potentially bundled surgery options for us in that given demographic? I see Doug on the call. Doug's been so helpful in educating me around this whole idea of bundled surgeries and those options, and recently spent some time with him. But if you haven't spent with Doug Geinzer, I highly recommend looking at his Power of Navigation white paper that he put out online. It's phenomenal. And so I appreciate that, Doug, and thanks for giving me your time and expertise to help me kind of sharpen our swords in our practice and do a better job. But that's just it. Like the HR team is constantly educating, webinars, talking to our employees about what's different about our plan. And the real focus, RVP alone doesn't just work by itself. It has to be on plan design incentives. So for our plan, when we advertise in a given town, and we've even considered, we probably will do it because we just do crazy stuff, but we were thinking about putting on a billboard near one of our corporate headquarters, main ones in Phoenix, about 790 employees there, is putting, come work with Vensure. We're in the business of business because we do a lot of things, not just benefits, but 401k, payroll, workers' comp, Venex, staffing, you name it. It's a long list, but where you can get free healthcare. And being able to fulfill that promise where an employee has no deductible, no copay, no out-of-pocket maximum, it's inherently tied to RVP. But the promise that we're making to employees is, look, if you trust us and follow the process, it'll be a lot easier. I think now too, with the inclusion of AIM in the Vensure family, it's making it a lot easier for us. We've seen about a 20% movement from a 20% increase in employees moving to our guided plans versus being on the Cigna. So, we have 2 swim lanes in our plan. We've got the Cigna plan, and then we have the RVP. We're seeing more people move to the RVP solution than ever, and I think that will continue to increase.
I appreciate you sharing everything that you've been sharing. I'm sure the folks on the webinar do as well. One of the things that I've always said is, we can do our part, and I think we do a darn good job at it. But it takes a village to make these things work. It takes an engaged advisor. It takes other good, a good administrator, a concierge, or medical management guidance. All those things play into the ultimate end user experience. And you guys have figured out that recipe and how to put it together. So I appreciate sharing that information.
Yeah, no problem. Yeah, I think the hardest thing for us, and Lindsay, if you want to jump to the next slide, has been this daunting subject. And I think it haunts every consultant who's considered doing RBP is rural hospitals. And Heath, I'm sure that you probably spend some hours up at night thinking about how to beat these guys up. But, some of the things that we've had some stumbling blocks with RBP obstinate providers. And I know that that's always a rough hair to comb on the RBP process, but I'm seeing it get significantly better. And I was recently, we have a lot of TPAs that we work with, certainly plug all of them, but I was out visiting the Cisco team in Dubuque, Iowa, where we principally manage the Vensure plan. And I was spending a little time with Dick Sigworth and Heather Harper and Brad Plummer, their president, the new benefits president of Cisco. And I was just absolutely amazed to hear that they've crossed sort of the chasm of where the majority of their clients that they manage are now RBP. And there's less traditional network self-funded clients than they've ever had. And that's a hell of a milestone for a TPA that's, out in the Midwest and works with a lot of traditionally longer legacy multi-generation companies like trucking companies. That is a huge pull. And if that's not a sign that what we're doing with RBP and these next generation plans is working, I don't know what is. What do you think, Heath?
I agree. We've been seeing this trend for years. There was a little bit of I think, a stall coming on the heels of COVID as, people are just working to maintain employee counts and health plans and all of that. But you're definitely seeing it pick back up again. And your knowledge base of what people are able to do and how to handle these things has improved. The threat of a balance bill, I think, has been, you can't say it doesn't happen. They happen, but I know I can speak for ourselves. We have the tools to handle it, whether that be through negotiation, contracting, or going down a MediShield legal play. But traditionally, they get handled. And you'd mentioned staying up at night thinking about how to beat up the rural hospital. I don't know that we take that approach either. Sometimes a partnership is what's needed, especially in a single provider town.
Yeah.
And having the ability to pivot to contracting and then use reference space to wrap around it can make sense. So there's a lot of different ways of doing this. And I think understanding your options and what you're trying to accomplish going into exploring these types of plans is critical. But we and you and others that have experienced this have that ability to have that conversation anyways.
Yeah, and what's great is I appreciate Kathy's question. Kathy, she's asked, I think everybody can see it, how do you handle children hospitals or children's specialty hospitals in RBP? And when there's no other, specialty hospital for pediatrics in a geographic area, well, I'm glad you asked it because I've experienced it multiple times with our own plan. An example would be, and this isn't necessarily a children's hospital, but Orlando Health. We had a team member who was already 3/4 of the way into the she was in her third trimester and came into our plan, and she's like, well, there's no way in heck I'm changing OBGYNs, and I'm already scheduled for labor and delivery. And then of course Orlando Health is sending us we don't take RBP, hell no, we won't go kind of letter, right? Well, we get on the phone with the 6 Degrees team, and we're like, look, let's hash this out with Orlando Health. Let's try to be, even though they're horribly known as RBP obstinate, we know and we're confident with the 6 Degrees team that even if they come up to an RBP obstinate situation, they have the tools and they have the ability to keep pushing that further until something successful happens. And quite honestly, as an advisor consultant, work with 6 Degrees on a coordinated effort, right? Where you're having that discussion with the C-level of that hospital, which is exactly what we did. Ultimately, we ended up doing a single case agreement for that particular employee to agree to the obviously percentage of CMS reimbursement. But the reality is this, like the BUCAs, Blue Cross, and I don't mean to speak negatively against, you know, any particular Blue Cross of anywhere, but many of the Blue Crosses of anywhere have less than 100% of Medicare reimbursement schema on their reimbursement now. And in Florida specifically, a lot of hospital facility reimbursements are 80 to 85% of Medicare. So what the hospitals, and this is just my opinion, and I recently spoke at a Florida Institute of CPAs meeting about fiduciary risk and health plans, and I didn't realize it, but walked into the room, it was all C-levels and hospitals. I'm like, oh, this is going to be fun. So they end up being very positive, but the short answer is, and talking and listening to a lot of those CFOs, they're not so inclined to be RBP obstinate because of RBP itself. They just don't like the third party interaction that is not originally comfortable with a carrier that they're used to in their playbook. Their SOPs that they work with and their processes and their 3-ring binders don't say, hey, you're also going to be dealing with reimbursement from RBP providers. But when they actually granularly understand that the self-funded plan has discretion to say 220% of Medicare or 190% for, say, providers, and that's a hell of a lot better than 85% of Medicare from a traditional Blue Cross of Anywhere plan, guess what? They open right up. So it's just, you know, not taking the RBP obstinance for what it is on the surface and going past that and going around it, just like when we all learned our early sales training, how do you get around the gatekeeper? How do you get through the gate? How do you get through? And so we're having tremendous success in those smaller rural situations like that, Kathy. But I appreciate you asking the question. We've done it in, we had a client in another example would be in West Virginia, a horrible, you know, quality organization, but I won't name the hospital, but it's a rural hospital there that we create a carve out for 2 clients in West Virginia that we won't allow their employees to see certain types of surgeons, only specific type ones because of quality. But they were also historically obstinate to RBP, and we were able with 6 Degrees to do a single case agreement. Again, same conversation as Orlando Health. Listen, this is not as bad as Highmark. What do you get from standpoint on average from Highmark Blue Cross? Oh, 100% of Medicare, 101, 105. What about 190? What about 220? Does that make sense? So they just are not familiar with the process versus being negative about it because they don't understand it. So I know RBP has been around for a while and it's starting to really take, the hooks are setting in now and companies are being more and more open to it, but there's still an opportunity for independent advisors to just rip it out there with RBP. So you can move to next slide if you want, Lindsay. Here's a big one. You know, Heath, we deal with this all the time. All the time. And it goes back to that in the beginning of our webinar, we talked about the three big things, right? And you know, musculoskeletal bone joint stuff is terrible. The amount of misdiagnosis, poor treatment, you know, some of those weird, wacky things like they work on the wrong leg or they they do crazy stuff in these hospitals, a lot of rural hospitals. But you know, working with a really professional, well-oiled, well-engineered, architected surgery bundle solution is critical for an unbundled health plan to operate. And we recently started working with Health Me, which was founded by Dr. Michael Havig, who ironically happens to reside down here in Naples. Doug actually made the connection to us, and we've started working with Health Me to do some more surgery bundle type of operations. But I'll tell you, we've had experiences with Coral and some other surgery bundle companies too, but I love seeing the execution of it. The best story I could ever have is one that Doug knows very well. Was we had an employee who had a shoulder surgery, and this guy was maybe not thinking straight or whatever. He decided to go out on ice in the winter with his daughter while he was in his rotator cuff rehabilitation. Well, that didn't end well, right? He flips over and lands on his shoulder again. And they were a Blue Cross Blue Shield South Carolina fully insured client. And then we got a hold of them and took it away from Willis and moved it self-funded, unbundled. And in essence, this guy walks into his HR office, he's got a pin sticking out, and he says, I think I need to get care on this. So it was a second revision rotator cuff surgery that was needed. Well, first off, talk about dangerous to the health plan, because you could be hundreds of thousands of dollars with an unknown factor of who's the surgeon going to be. If they go to Blue Cross and they do the pin the tail on the donkey find a doctor process, and they find a random orthopedic guy that has no skills, that's really identified and drilled in for a second or third revision rotator cuff, but using a surgery bundle option, not only identified the right doc, they reviewed the case notes. We went through a couple of different docs that refused it, finally found one who was an expert in second and third revision shoulder rotator cuff revisions. And he did the surgery just absolutely wonderfully. Employee was back to work after the rehab. Guy actually went and had the opportunity to visit him, and he was showing me how he could actually lift better than before he got injured. So, having the right surgeon is clutch. And obviously being able to have that flat fee that's negotiated and flows through the self-funded plan is critical. And by the way, going back to the AI thing, if you're talking to advisors, or if you're a vendor on the call and you're trying to get more business from brokers, advisors, which obviously you all do a really great job at, you got to be encouraging these consultants to start doing these next gen strategies, and maybe taking, appreciate you spending time with us on the webinar, but these are real stories of applicable examples of how these vendor solutions work. But all wrapped in the kind of like, bow of RBP. And that's just the start of it. All these other solutions are critical stages and steps as part of that same plan. Heath, what do you think?
I couldn't agree more. It's like I think I mentioned this earlier in this discussion, but taking that first step is the way to the end game. But you just got to get started. There's a lot of resources out there that you can utilize. I know that at 6 Degrees, we're more than happy to help. And one of the nice things, if you think about surgeries and contracting and all that, we can help with that, but there's also other resources that can assist there, and just take advantage of the knowledge base that's willing to share. Everyone's here to help you down the path. The more we work together on these things, if you think, people ask me, who's your biggest competitor? And obviously there's other vendors out there that do what we do, but if you think about who really are our competitors, it's the bulk of healthcare, the network models out there that aren't doing anybody favors. So I think if we can raise the tide for everybody, we all benefit. So.
Yeah, I mean, I liken it to the sort of like statement of the obvious, especially for the attendees that are on here, those that I know have a lot of this knowledge, but it's always good to sort of like hear how others package it, right? And hear how others use the nomenclature so they could either increase their style or try something different, right? But we constantly talk to C-levels about this whole idea that health insurance carriers have federally controlled margins, and they just can't make the profitability for their shareholders they could have pre-ACA, and it's only gotten worse. And so you look at these like Blue Crosses of everywhere types of franchises, and if you're able to get some of them to talk to you transparently, you'd be shocked when you start to hear things like I'm hearing around the country for some of our advisors that have those relationships, like the average group at Blue Cross of somewhere that's a large group between 51 and 300 employees, their average participation is 30%. What? So like, remember the days, I mean, maybe check the box for, I'm not that old, but hell, I started in the early 2000s doing health benefits. And I remember when large groups would require 70% participation. We're so far from that now. It's unfreaking believable that an average Blue Cross of Somewhere's participation in their group block for groups that are between 51 and 399 in that range is 30% participation. So the only way for them to increase their marginalization, right? And if you watch the documentary, there's a really cool visual that Bart Camerato, as our director, made. When you squeeze that balloon, right, and the carrier's margin is a percentage of premium, the only way to squeeze the balloon is increase the premium if you have a smaller segment of people who are participating. So they're driving people away. And so I think that the window of opportunity could not be opened any greater at this particular juncture in our current status. And I tend to think that for advisors that are in the field now, I think that there's at least a decade or more of just open playing field here to do these next gen style plans. And that's a hell of a good thing for all of us that are involved in these. So I'm excited to see this movement continue, and I'm excited to see what new innovations that our vendors come up with, and welcome all the innovators to creating more innovation so we can disrupt more.
Definitely gives you a nice differentiation over the average consultant out there.
Yep, agreed.
So Dan, we're down to our last 4 minutes. So we got a few, probably another minute for questions. If anybody's want to lob one in there, we can do that. Or if you have any final thoughts, feel free to share that, and then we'll get to the closing ceremonies here.
Yeah, I mean, look, for me, what I'm presently doing with my advisors, I'm working on enterprise and jumbo stuff, and so are some of our other key people. But our 20 benefit sales consultants that work for us now, they're all, if for those of you out there that are either agency principals and working with your advisors, or you are a vendor to a lot of advisors that trust you, the best advice you can give them is to really have prospecting via science, and hold their teams accountable to making the calls, doing the dials. From one person to another, it's no different. It's just a matter of sticking to their guns and getting it done. It's just a science. The more calls you make, the more successes you have. You're going to have yeses and nos. It's just inevitable. And obviously our story, when we're as benefits consultants, our story changes based on the target market that we're going after. But it couldn't be more exciting to be able to leverage some of these tools like the Johnson & Johnson fiduciary lawsuit, or the Granger lawsuit, or the Osceola County Schools lawsuits that are all happening, that traditional advisory firms like, Gallagher or some of the other ones that are named in those, they're all getting wrapped around the axle of those, and the carriers are getting wrapped around the axle. It is so easy to create pain for someone right now who's in a decision-making capacity for a large group health plan. So easy. But teaching the new advisors how to learn that, frame it up, do their prospecting, make it a science, results will happen. So that's my my parting advice for anybody that's out there.
Good stuff. Well, I think today, not only did we learn about AI and underwriting, but a wealth of additional information included. So thank you, Dan. I greatly appreciate it. Dan's contact information is on the screen right now. I'm sure he'd welcome any questions or additional dialogue that may come from this. Feel free to reach out to me as well. I think that's the next slide, but we're down to our final minute. Let's hit the September Fireside Chat plug, which means you get August off, guys. I know it's probably going to make some of you sad and cry, but if you need some Fireside time, feel free to go to our website. You can watch the last 4 years of Fireside Chats. They're all there. Otherwise, I'll see you on September 18th at 11 a.m. Pacific time. We'll have Dr. Eric Bricker join us of A Healthcare Z. He was a guest here a few years ago, does a great job. Some of you may follow him online as well with some of these YouTube clips. So always entertaining. Look forward to that discussion. Dan, thank you very much. Appreciate your time.
Thank you, Heath. Thank you, Lindsay.
Take care, everybody. Enjoy your summer.